I have no demonstration, unfortunately. Thank you very much for the invitation. Thank you, Mrs. Chairman. Usually you say Mr. Chairman, now I say Mrs. Chairman. Well, Martin Tobin showed that the cradle of medicine was Padua. And this makes Paolo Navalesi in the first row very proud. However, I need to remind to you that the oldest university, Western universities, is Bologna, 1088, really. Now, the other thing that I have to say is that when I realized that I have to give a talk about impaired gases change, I got really confused, because on one side, you run the risk to do it too simple, and on the other side, too complicated. So I was really, as I said, confused. I tried to do something in the middle, but this is a basic course. So at the end of the day, I think I did something very basic about gases change, and I think it's a little bit boring, but this is the start, I think. Now, we know that the main causes of respiratory failure are 4. We receive more than 4, but when we talk about respiratory disorders, we know that these are the main drivers. Diffusion alteration, hypoventilation, shunt, and ventilation perfusion mismatching. Well, what is ventilation? Well, during what we call ventilation, the alveolus expands with fresh air that has flowed down the bronchial tree from the mouth during inspiration. And thereafter, the alveoli reduce in volume during expiration, returning gas up to the bronchial trees and then to the mouth. Normally, all the alveoli are ventilated and perfused. Well, I think there is a fundamental principle when you talk about ventilation in human beings, and also in animals, I guess. And this is the fundamental principle of conservation of mass. Within the lungs, every oxygen molecules that is inhaled by us, but not exhales, diffuse from the alveolar gas to the blood, and therefore can be found in the blood. Well, we know that we have 300 million alveoli that, as you know from the basic physiology, are not equally perfused and equally ventilated. Lungs, even in healthy people, are far from being uniform, and this heterogeneity has negative consequences for gases change. Here is what John West described as the West zone, zone 1, 2, and 3, and you can clearly see here the effect of gravity that is even more striking in this slide, when you can clearly see that the effect of gravity is very pronounced, especially concerning perfusion, that is blood flow. Well, before getting into the different causes of alteration of gases change, we need to remember some very basic points. First of all, we know that oxygen content is the total amount of oxygen within a certain volume of blood. As you can see here, is determined by hemoglobin concentration, its extent of saturation, and the partial pressure of oxygen. The other point to start with is how oxygen is transported in the blood. Oxygen transport is the rate at which an oxygen molecule is being moved by the circulatory system from the lungs to the periphery, to the organs, to the solid organs, to the limb muscle, etc. And oxygen transport, DO2, is determined by oxygen content. We talked about oxygen content the previous slide, and the cardiac output. Typically, oxygen transport is also called oxygen delivery. That is a more common way to define it. Finally, we have what we call oxygen consumption. Well, oxygen consumption is very simply the rate at which oxygen is being utilized by the periphery. Once more, by solid organ, by skeletal muscle, etc., etc. And is defined as the difference between the oxygen contained in the arterial blood and mixed venous blood times the cardiac output. Well, we know that during the gas exchange between the alveoli and the capillary system, there is no active transport involved. And this process, therefore, does not require any energy expenditure by the organism, because it's mainly driven by the difference in pressure, as you know, once more from the basic physiology. Oxygen got this kind of behavior, higher pressure to lower pressure, and CO2 as the other way around, higher pressure to lower pressure. Well, one of the main problems to understand gas exchange is how effectively is the oxygen that we breathe brought into the lung, making it into the bloodstream. Well, this has been defined as what we call alveolar arterial oxygen gradient. This is the difference between the partial pressure of oxygen in the alveoli and the pressure in the blood, simply. The higher is the gradient, the worse is the performance. Well, having said this basic of to understand gas exchange, we move, as we said, to the causes of hypoxia. We add here few more causes of hypoxias, as I show you in the first slide. And the first one is the reduced inspiratory pressure of oxygen. That is the pressure of oxygen in the air. That is, as you know, a totally different issue, but this is hard to learn by medical students. PO2 is different from FiO2, as you know, and this is strongly dependent on the atmosphere. Where going to altitude, going to the mountains, going on the airplane, there will be a decrease in atmospheric pressure will result in the decrease in the alveolar PO2. This will not cause hypercapnia for a simple reason, because as Dr. Hank showed before, Leo showed before, ventilatory stimulation from hypoxia will reduce arterial CO2. This all particularly true when we face with a patient on oxygen therapy, or I think even worse, in patients with a borderline saturation. This is a review that we wrote with Begun a couple of years ago, and I found this cartoon quite interesting. This is one normal subject, I would say, with 99% of oxygen saturation at the sea level, and this is what is happening to saturation at the altitude of 8,000 feet. I remind to you that 8,000 feet is around 2,500 meters, more or less. This is the pressure that you get on the aircraft cabin. Well, in normal, I would say, subject, you have a drop in SiO2 that is quite consistent. On average, you reach the value of 93, 92, but it is very much more pronounced in those borderline patients. Well, if you see a patient in your office with 93% of the saturation, what are you going to do? Are you going to say, be careful to go to a long trip on the airplane? You say, don't care, or you say, you need to carry oxygen. Well, very few, very few institutions around the world have the possibility of assess this in a special kind of cabin. In my country, I'm not aware of any single hospital able to perform this kind of test. Anyhow, this is a simplification of what is happening in a patient with borderline saturation. Going on an airplane trip, you can get a consistent reduction in oxygen saturation down to the 80s, like 80, 82%. So please, as you know for sure, be very careful when you see this kind of borderline patient. Well, let's move to the most important causes of impairment in gas exchange. Ventilation perfusion abnormalities are for sure one of the main drivers of respiratory problem. One important point to remember, it is very rare in medicine to see a patient with respiratory failure that have only one cause of respiratory failure. Here I highlight the disease where ventilation perfusion mismatching is the major driver of respiratory failure. But they may have, according to the different disease, also other drivers of respiratory failure, like shunt, diffusion alteration, and sometimes even hypoventilation. Well, the disease characterized by the higher degree of ventilation perfusion mismatching are cardiogenic pulmonary edema, pneumonia, and pulmonary embolism. Well, this slide is very familiar to all of you. This is a normal subject. The alveoli are well ventilated, and there is a very good perfusion. While when there is a VQ mismatch, you either have a low ventilation or a very low perfusion. In some case, you may have the concomitant of low ventilation and low perfusion. Well, this is what we call the normal ventilation perfusion equilibrium. That is one. Here you see that alveolar cambium and carbon dioxide partial pressure in homogeneous regions that are very rare to observe in real life at more or less an alveolar PiO2 of 100 millimeter of mercury and 40 millimeter of mercury. Remember, this is alveolar PaCO2, it's not arterial. Well, when, as I said, ventilation perfusion is normal, about 1. As I said here, these are the values of alveolar O2 and alveolar PCO2. Well, if you shift the curve on the left-hand side, if a region, in other words, became poorly ventilated, this is mainly due to airway narrowing or airway obstruction, but perfusion remained normal, the ventilation perfusion ratio of that region for sure is reduced. And as you see here, alveolar O2 is markedly reduced. And therefore also blood oxygen concentration will fall. CO2 will rise, but only by a very small amount. What is going to happen if you move on the right-hand side? In other words, if difference rise. Well, this is very often due to vascular obstruction, that means reduced perfusion, and alveolar O2 rise a little bit, while CO2 tends to fall. But because of the differences in the two dissociation curves, oxygen concentration rises only little, but as you can see here, alveolar CO2 and CO2 concentration in the blood fall considerably. Well, to sum up, when we face a low ventilation perfusion ratio, O2 is seriously affected, and for sure more than CO2. When we are in presence of high ventilation perfusion ratio, we develop CO2 is the more affected lung. Well, to know is that most of the lung disease can cause significant ventilation perfusion inequality, although the physiological and structural mechanisms can be extremely variable from disease to disease. If ventilation perfusion abnormalities develop from every kind of disease and pulmonary uptake of oxygen are reduced, it is obvious that the tissue will not be able any longer to sustain metabolic rate, and if the problem is severe or very severe, death will ensue unless the body finds a way to compensate. What are the ways of compensate this? There are at least three main mechanisms. The first one is to simply extract more O2 from the blood to restore the O2 flux. And this change in O2 usually are very rapid, and the process is totally passive. This simple strategy is very often very effective. The second compensation is to increase alveolar ventilation. As ventilation is increased, ventilation perfusion ratio will also increase, rising alveolar O2 and also arterial O2. This compensatory process is also very common, and when we do not face a severe airway obstruction, this should be very often quite effective. Last, the third compensation is to increase cardiac output. Why increasing cardiac output? Because this mitigates the fall in O2, because it allowed less O2 extraction in the tissue, rising O2 in the venous blood, returning to the lungs, and as a result, increasing arterial PiO2. This mechanism is very effective, but only in the absence of a cardiac disease. Well, alveolar hypoventilation. Alveolar hypoventilation is the common feature of COPD patients. Is the main cause of gas exchange. But as I said before, remember that even COPD patient may face other driver of gas exchange impairment. Well, we know that alveolar hypoventilation is mainly driven by respiratory pump problem. Leo already showed how the drive is working. Sedative may impair the central nervous system, can be mechanical impairment due to neuromuscular disorder, kyphoscoliosis, and at the end, we may face what we call respiratory muscle fatigue, especially in patients with chronic obstructive pulmonary disease. Contrary-wise to most of the ventilation perfusion problems, usually alveolar hyperventilation produces on one side a decrease in oxygenation, but on the other side, CO2 markedly increase. The main driver of alveolar hyperventilation is dead space. The question is why that space is so important. Because to move air in, we need power that is mainly driven by our respiratory muscle. To meet oxygen delivery and CO2 removal, we need a certain amount of fresh air that must leave in and out our lung per minute. And as that space increases, more air has to be moved to maintain the same alveolar ventilation. Therefore, increasing that space means decreasing efficiency and decreasing work of breathing. Well, this is the main consequences of alveolar hypoventilation. If you reduce by little, I mean few liters per minute, alveolar ventilation, this will result in a marked difference in PaCO2 that is going to increase dramatically, but also in PaO2 that is also going to be decreased. Well, during alveolar hypoventilation, the volume of gases that is reaching the alveoli is reduced, as we say. Leo already showed this formula. Arterial CO2 is related to CO2 production times a constant and alveolar hypoventilation. Alveolar hypoventilation, I remind to you, is the difference between the tidal volume and the dead space times the respiratory rate. Therefore, alveolar hypoventilation and PaCO2 are inversely related. Well, let's take these two patients. It's very simple to follow. Patient number 1 or 8. Tidal volume of 500 ml, as most of you in this room. Respiratory rate on 10 breaths per minute. Minute ventilation is therefore 500 times 10, 5 liters per minute. Easy. Patient is coming in. He's breathing different from you. You still have 5 minutes of minute ventilation, but tidal volume is reduced by half, 250, and respiratory rate obviously is double, is 20. So minutes ventilation is the same, but the breathing pattern is totally different because alveolar ventilation is different. Here, in a normal subject, if you do 500 ml, your tidal volume minus a fixed dead space of 150 ml times 10 is 3.5 liters per minute. In the patient coming in the room with higher frequency and lower tidal volume, alveolar ventilation is markedly reduced, 2 liters per minute. Well, if you make a simple calculation, normal subject has breathed normally with about 30% of that space of tidal volume. A COPD patient in a stable phase is using about 60% of the space of his tidal volume. Well, this is a very simple schematic way of showing how do we breathe and why is important this cartoon concerning alveolar hypoventilation. This is a normal subject. As Leo showed, in this room, more or less, we can develop a pressure of 100 ml to make 100 centimeters of water, sorry, to make things simple, and we all face an elastic and a resistive load. But we used to develop a tidal volume of 500 ml, a very small proportion of our maximal inspiratory pressure. Let's say we use 10%. So this balance is totally on the right-hand side. When in stable COPD, the situation is a little bit different. First of all, the elastic and resistant load may be increased, but inspiratory muscle pressure, the maximal inspiratory muscle, is reduced. Let's say here is around 70 instead of 100. And therefore, since the patient with stable COPD has to face an increased elastic and resistance load, and the maximal inspiratory pressure is reduced, is usually breathing with a 25% of his maximal inspiratory pressure. Well, what is going to happen during a COPD exacerbation? Well, now things are getting dramatic because due to hyperinflation, most of this patient has a reduced inspiratory muscle pressure, not because the muscles are weak, but because the muscle are placed in a length tension curve, very bad position. And on the other side, the elastic and resistive load is markedly increased. So just for these two reasons, decrease capacity and increase load, COPD patient during an acute exacerbation, they breathe to get a tidal volume of 500 ml to very high proportion of muscular inspiratory pressure to maximal inspiratory pressure. Therefore, the only way to reduce this is to reduce tidal volume. Remember, these patients were ventilated with 500 ml, but the price they have to pay was way too high, 50% of their maximal inspiratory force. Now, if they decrease tidal volume, they reduce also the effort they need to make. But this is a price to pay. And the price to pay is called hypercapnia, because tidal volume is reduced. And as I showed you a while ago, that space became a really huge part of their tidal volume. So the only way to restore a good alveolar ventilation is to support this patient. This is a classical example of how mechanical ventilation works. This is a COPD patient during an acute exacerbation of COPD, and this is a tidal volume around 250, and breathing frequency is very high. The total duty cycle is 2.5 seconds. Here, the same patient under mechanical ventilation, tidal volume increase up to 500 ml, and breathing frequency decrease. So once more, why this patient? They choose to become hypercapnic, reducing tidal volume. This is a sort of protective mechanism. This is a very old study by Scherer and Monod back in 1956. What the author did was very simple. They asked a normal subject, sustain an isometric effort, like lifting a suitcase with 30 kilos. The more the suitcase was heavy, the less they could sustain the isometric effort. Very heavy suitcase, you need to drop it very soon. Very light suitcase, you can keep for a longer period of time. Ventilation is even more complex because it's not only a matter of how heavy is the suitcase, but how long are you going to sustain intermittently your suitcase? In other words, you can leave the same amount of load, but you can just stand for 2 seconds and rest for 1 second, or the other way around. Leave the suitcase for 1 second and rest for 3 seconds. And this is a concept of respiratory muscle fatigue, and this is an old paper by Belmar and Grassino that they first developed the concept of the fatigue threshold. If you combine the percentage of effort compared to the maximal effort you can make and the inspiratory time over the total duty cycle, that means how long are you going to sustain your breath, you may draw this curve that is called the fatigue threshold, that it was in the range of 0.15 to 0.20. Now, normal subject and stable COPD, they still work below the fatigue threshold. COPD patient during an acute exacerbation, they breathe above this fatigue threshold. And they have no choice. Actually, they can't sustain a breathing pattern forever when they overpass the fatigue threshold. So as a clinician, you may add the patient using mechanical ventilation, either invasive or non-invasive. As a patient, you only have one choice, go back down here. And going back down here means reducing tidal volume, and reducing tidal volume means reducing the effort here, but you have a very high price to pay with hypercapnia. Well, now let's move last 3 or 4 minutes of the other two main causes. Failure of diffusional equilibrium. We know that arterial capillary diffusion alteration are mainly observed in interstitial lung disease, because in all the other lung disease, diffusional equilibrium is rarely seen. And at the beginning of this disease, you only see a gas exchange impairment during strenuous effort. We know that the diffusion capacity of CO2 across the blood gas barrier is much greater than for oxygen. This is because of approximately 20 times fold greater physical solubility of CO2 in the blood gas barriers. However, the capacity of the blood to hold CO2 is 10-fold greater than of blood to hold oxygen. Well, diffusion of gas from the alveolus into the capillary bloods depends on diffusivity, is itself in the membrane, the area. The larger is the area, the larger is the diffusion capacity. The thickness, we know that interstitial lung disease, thickness is only the main problem, and then the short transit time. Transit time is also called contact time. How many milliseconds is the blood in touching the barrier? And this is the reason why most of the interstitial disease patients, they show gas impairment at the beginning during exercise and not during rest. Last 3 slides, venous admixture, that is called shunt. Shunt is fortunately quite rarely seen in pulmonary disease, and shunting is defined as blood passing from the right to left side of the heart without ever seeing alveolar gases. So everything is not oxygenated. This can be due to cardiac shunt, can be either atrial or ventricular, is typical of congenital heart disease, and lung disease associated with atelectasis, or alveolar filling with fluid, or surge debris. It may also occur in lung disease associated with large arterial-venous connection, like cirrhosis and telangiectasis. Most of the patients with COPD do not have problem of shunting, but patients with acute lung disease, as I told you before, like pneumonia, acute lung injury, ARDS, they may have a certain amount of shunt. Shunt cannot be corrected with O2 or better, depending on the amount of shunt that you have. Here is the response to different concentration of FiO2 in normal subject with 0 shunt and with increasing amount of shunt. You see that if your patient has 50% of shunt, there is no way that you can correct arterial PO2 even with 100% of FiO2. Last slide, you need to also consider that that slide that I showed you before is not so simple because everything is also dependent on cardiac output. Keeping shunt, for example, constant at 20% with an inspired FiO2 of 100%, arterial PO2 is clearly dependent on the amount of cardiac output. The lower is the cardiac output, the more difficult is to correct arterial PaO2 even with 100% of oxygen. And I'm sorry to bother you a little bit, but this was, as I said before, a very hard task to achieve, and I tried to keep as simple as I could. Thank you very much.